Charlene, would you like to introduce yourself?
Yeah, hi everyone. I'm Charlene. I'm also a global health fellow at the BRI, so working with Rihanna, and we'll be co-hosting this grand round.
All right. A bit about the Global Grand Rounds and the Dharura organization. Dharura is an organization which supports ethical, sustainable, and equal and reciprocal global emergency care for healthcare partnerships. Dharura also supports mutual development through sharing knowledge, skills, and innovations for which this Global Emergency Care Grand Round aims to achieve. We have a wide variety of speakers and topics being shared and discussed each month, with speakers sharing topics across all aspects of emergency care, including case reviews, research, audit, QIPs, and migrant care, as we're doing today, to name a few. Charlene would just like to take you through some ground rules now.
Yes, so if everyone could turn off their microphones, please, besides the speakers, obviously. And then if we could turn our cameras on to have a little bit more interaction and see some of our faces, that would be grand. Um, if during the talks we could post our questions in the chat, and we'll then later on have time to read them out and have a discussion. We'll give the speakers a heads up after like 15 minutes that we're coming to an end. So we have time for a discussion for 5, 10 minutes. But it's also okay to go a little bit over or under. If we could start off by writing our name, our role, and where we work in the chat, I'll begin to do so we know who is attending. I've started the recording for the session. I hope everyone is okay with that, and we can then later watch them back. And for the people that miss it, they can watch it at their own convenience. Right. So yeah, if we start putting our names, role, and hospital affiliation in the chat, they'll be much appreciated.
Amazing. Um, we would now like to first introduce our first speaker, Jacob Burns. Jacob has been working with MSF since 2018, starting in the field in communications. He worked in Turkey, Iraq, Palestine, Jordan, and Yemen. After a stint at MSF's Center of Reflection in Paris, he has gone to manage operation in conflict zones in Gaza and Haiti, and is currently setting up a mental health program for asylum seekers and refugees in the UK. Jacob is going to take us through the reflections on MSF's provision of healthcare to asylum seekers in the UK today. Over to you, Jacob.
Thank you very much. Thank you very much for having me. Yeah, so I thought I'm afraid I'm not a clinician. So in terms of clinical insights, I don't have much to offer. But I thought that what I could do is maybe give a brief outline of the history of MSF's work with asylum seekers in the UK. And talk about what we're currently trying to set up, and also maybe try to draw out, I suppose, some of the themes that have emerged from our work with asylum seekers in this country, and I think about some of the challenges that poses for a humanitarian organization trying to learn how to work in the UK. MSF is an organization that's currently working in over 70 countries around the world, and for some of those that's been many years that we've been working there. But for our work in the UK, although we've had an office here for 20-30 years, I think, that's been involved in recruitment and fundraising, actual operations only started in 2020. There'd been some work around the time of the big kind of migration refugee crisis, 2015, 2016, to see if, like in other European countries like France and Italy, where MSF was starting projects, whether there needed to be a project in the UK. And at that time, it was felt that actually kind of this system was more or less holding up and more or less able to meet its responsibilities towards people seeking asylum in the UK. What changed in 2020 was unsurprisingly COVID. So all of a sudden, the asylum system grinds to a halt. Many people are suddenly being housed in hotels rather than, as was previously the case, being housed in privately rented houses. So you've got quite different ill-adapted accommodation being provided to asylum seekers whose future is suddenly much more uncertain because of the pause in asylum processing, at the same time as there's a real hardening of legislation in the UK. There's a real hardening in terms of the political attitudes that the government at the time, which was conservative, had towards migrants and people seeking sanctuary in this country. And so we started working in one of the new, at that time, what were called large sites. So in order to deal with suddenly this mass of people in the asylum system, the government started turning places like old air bases, old army barracks, even a large boat into accommodation for asylum seekers. And this was felt to be a point at which MSF could do something. MSF knew how to work in those kind of camp-like settings. We saw that there was a crisis in terms of number of people in a system that was struggling to meet their needs. And so MSF took the decision to intervene in the UK for the first time. I would say we immediately came up against the set of problems that I think have remained the same set of problems for MSF working in the UK throughout the life of these various projects. So one was figuring out how to get around the quite strict regulatory requirements that exist in this country in order to provide healthcare. How can you do something in the UK where actually it's quite difficult? You can't, as you can even in a country like France, just turn up with a van and start seeing people in the van and provide GP appointments. This country, there are very onerous regulatory requirements for providing healthcare, and it wasn't easy to figure out what to do that MSF could do with the type of registration that it had. There was also a lot of thinking about avoiding duplication. There is the National Health Service in this country. There are entitlements to access to healthcare for asylum seekers. Even people who are quote unquote illegal immigrants in this country have access to free primary healthcare. So how do we do something that doesn't simply duplicate what's already being offered by the system, or that somehow taking the responsibility away from the government to meet its obligations towards these people? And related to that then is how do you do something that has clinical impact? Where's the added value of an organization like MSF coming in and offering primary healthcare if primary healthcare is already being offered by the National Health Service? But also what's been really difficult, I think, has been negotiating internal expectations. MSF likes to think of itself as kind of this flexible organization that's very innovative, that turns up in all these different places and does something new each time. But actually, what we see quite a lot is that MSF is quite set in its ways of working. It's got particular attitudes that it takes towards particular problems. And quite often it wants to copy paste the response it's had in one place into another place. And I think that that's been really difficult to navigate in MSF. You don't hear quite so much as you used to in MSF, this questioning of why MSF should spend its money in a kind of a high income country. That doesn't seem to be so much a concern, but the type of response, what sort of things MSF should be doing in these high income countries, that does still remain a controversy. And also, as we go on to look at the next project that we had in the UK, so we worked briefly in Napier. That was with one operational centre of MSF. They quickly sort of got bored or didn't think that it was actually very relevant for MSF to be working in this large site Napier. And so that project closed. Then in 2022, when there's a place called Manston, which is the processing centre for people arriving by small boats across the English Channel. And in 2022, there was suddenly a huge spike in the number of people arriving, and Manston became overwhelmed. There was also all of the legislative problems that I mentioned earlier, where people were not having their asylum claims processed. And so people ended up spending weeks, I think even months in Manston, which is essentially designed for you to be moved through in 24, 48 hours. And we started seeing preventable diseases, outbreaks of vaccine preventable diseases in Manston. Someone died of diphtheria, which, I think in the UK is relatively unheard of. And this prompted MSF to say, oh, wow, this seems really bad. We're going to go back and try and work again. So a different operational center came in, and again, there was a difficulty about negotiating these internal expectations. So the idea at the beginning was to find one of these large sites. It ended up being a place called Wethersfield in Essex, which is not a detention center, but it's an old airbase where people are housed. They're in theory free to come and go, but actually it's very remote. It's very isolated. There's not really anywhere you can walk to. You have to get the bus everywhere, and it's an old airbase. It feels like a prison. There's barbed wire. There's a firing range where you can hear the shooting, which is obviously not great for people who are dealing with PTSD that's caused by a conflict. And the struggle for the operational center at that time was how to reconcile the desire to see a large number of patients. They wanted to do primary healthcare, reconcile the desire to see a large number of patients with their hesitancy to be seen to become complicit in this accommodation site that they felt was quite unethical. And again, how to navigate the regulatory environment in the UK, because we're not registered with the Care Quality Commission, which is the body that regulates the provision of medical care. And so the way that they got around this was forming a partnership with another organization, Doctors of the World, which is MDM's UK branch, who are registered with the CQC. And they had this mobile clinic van, which was also registered with the CQC. And to avoid this kind of impression of complicity, the van was parked outside the gates of the site a number of days a week, and people from the site would walk out to the van to obtain a GP consultation. But what we were doing wasn't, I would say, didn't turn out to be so much the provision of primary healthcare, because on the site there was a primary healthcare provider, a private one, who, while far from perfect in their work, if you turned up and you had a fever, you'd get some paracetamol and some antibiotics. But what they wouldn't do is provide medical evidence for people's requests to be transferred from the site. So the Home Office has suitability criteria for people housed at the site. And if you have a serious physical or mental health problem, for example, PTSD, you're not supposed to be housed there. But the assessments that the Home Office do when people arrive in the country are not very thorough. And so a lot of people with PTSD, with psychosis, even schizophrenia, would end up in this site, which was completely unsuitable for them. And the site at that time was very chaotic. There was actually quite a lot of violence between people housed at the site because the environment was very pressured. People were spending an awful long time there with no knowledge about when they might leave because their asylum claims were not being processed. Sorry, Rihanna, did you want to say something? Oh, there, you've got like a yellow box around you. I thought you had your hand up.
No, that wasn't me, sorry.
Okay, no worries. And so the on-site GP would not provide medical evidence for people's requests to the Home Office to be transferred off the site. So what we ended up doing was doing a lot of that history taking, of that assessment, of writing letters to say, we have seen Mr. Such and such, he presents with the symptoms of X. The other thing that we ended up doing an awful lot of was dealing with mental health complaints. So 62% of the 301 people that we saw at the site presented with severe mental distress. And it quickly became obvious to us that actually the needs that people had were not so much in physical health, that people had physical health needs, but they were able to be met by the National Health Service. Where the National Health Service was really struggling was in understanding the needs for mental health treatment for asylum seekers, and being able to put in place services that could adequately meet those needs. So understanding, the fact that someone can't wait on a waiting list for 2 years to access treatment because they're being moved around by the Home Office every couple of months, that they need interpretation, that the person is going to have a whole host of immediate stressors that they also need help with. But most of all, that these are people for whom it's very difficult to trust other people, and that if you're going to engage long term with a mental health service and hope to make some form of progress in treatment, building that trust is absolutely key. And so that's learnings that we've taken forward. But again, we struggle to make the project really work, and we certainly struggled to convince the operational centre that what we were doing was valuable. They wanted to see 30 patients a day, handing out paracetamol, get the numbers up for the reporting, and that was just simply, that was never going to happen with the type of patients that we were seeing, and with the operational posture that we'd taken, sitting outside the site. And it also, that was very difficult then to really have a clinical impact for that many people, because you were relying on people coming to you. You were relying on perhaps a segment of the population that was still willing to actively seek out healthcare rather than being able to go and meet people where they were at. So anyway, there was all these mismatch of expectations. There was also difficulties in the partnership with Doctors of the World through the fault of nobody, but just very different ways of working. And so this project came to an end at the end of last year. And finally, a third operational centre has come in. And I started working in this job in October last year with a brief to reimagine what we wanted to work on. And for me, I very much identified this mental health, this learning about mental health, and saw it as very, very important. And I also thought that where MSF could add value was in the clinical treatment of mental health problems. Often in MSF, I think there's quite a tendency to want to provide quite basic psychosocial activities for people on the move. But actually in the UK, what we see is that that's not really a need. There are very often very good voluntary organizations providing quite a lot of low-level practical and social support to people seeking sanctuary, to people who already have their status. But where they really lack an ability to help people is with some of the more tricky mental health problems that people are having. It's very difficult to refer into the NHS and have that referral accepted and have the person seen. And it's really not that many organizations that have the expertise that are able to deliver some form of mental health treatment as opposed to kind of psychosocial support. And I've worked in a couple of different places with MSF, where places like Nablus in the West Bank, where we have a psychotherapy clinic that has been there for many years, dealing with people with trauma from both the ongoing occupation, but also trauma that's happened because there's sexual abuse in the family, there's other kinds of family violence or other kinds of trauma. And so I thought that if we were able to deliver high quality, high intensity mental health care in that setting, then there should be no reason that we couldn't deliver it here. And also with the problem of regulation, it's easier to set up a mental health project in the UK than it is a physical health project. So that was quite a nice answer to that project as well. So we did an assessment of a model that we wanted to put in place. It's a stepped care model where, with some external outreach activities, where we're going to go into hotels, we're going into to places, other places where refugees and asylum seekers are congregating, delivering outreach services. At the second step, we are delivering psychoeducation, so teaching people about trauma, what it means, what the symptoms of trauma look like, and some of the strategies for managing those symptoms. So quite a short-term course that can be helpful for people who perhaps aren't ready or willing to open up the trauma and try to look at it deeply, but just want something to help them kind of keep things together while they wait for their status, perhaps. And then at the third stage, eventually we'll have our own clinic where we'll be offering 12 to 20 weeks of trauma-focused therapy. All of that with interpretation, and all of that with caseworkers being very important to the service as well. So people who are acting a little bit like care coordinators, trying to address some of these immediate social stressors that can mean it's very difficult for people to engage with mental health services. We're in the process of opening up at the moment. It's quite a complex service to try to open up, and I think we're still also dealing with some of these internal debates that happen because some people think we should just be doing something that's less clinically ambitious, that we should just be providing some form of social support for these people. But I'm quite insistent on the fact that we need to, if we're going to work in this environment, find something that's clinically impactful, because it's only if we're clinically impactful, I think, that we are avoiding the risk of duplication, actually having some form of added value as MSF. And the hope is that we've planned the project for 3 years, and across the life of the project in 3 years, that we demonstrate the efficacy of the model, and that we're eventually able to look for a partner either in the third sector or in the NHS to hand over the project to, and that way it can become sustainable for the future. That's me. We're on for nearly 25 minutes now, so I'll stop there, but very happy to take any questions. And thank you very much for having me.
Thank you so much, Jacob. That was really great. If anyone has any questions, feel free to pop it into the chat or just unmute yourselves and ask.
I might just start off with a question, if that's all right. How many people were kind of on site?
At Wethersfield, at that time, there was a capacity of around 600 people.
Yeah. And then the people that were involved with MSF. So was
how many people were working? Okay, so the team was generally 2 GPs out at any one time, with then a logistician who was also kind of acting as a receptionist, caseworker, logging people into the system. But so the GPs would do the appointments, and each appointment would tend to last around an hour. With telephone interpretation, it obviously takes some time to explain things, to get into detail, and also a lot of what would initially be presented as the problem would later on come to actually be a symptom of something else. So people would very often come with back pain or other form of non-specific physical pain that, once you started to have a conversation with the person, you'd understand that actually that was a physical manifestation of a mental health problem.
And so it was telephone interpretation that was used usually.
Yeah, because of the remoteness of the site, and because it was operating on a drop-in model, so it wasn't possible to have physical interpreters there. At least not for all of the languages. There was a plan at one point to start having what MSF call intercultural mediators, but then with the kind of turnover in the operational center, then that was they didn't end up being recruited.
Yeah, that makes sense. I mean, that seems like a big organizational challenge, especially with, I mean, I guess with the people also opening up about mental health issues, and then having that barrier with a telephone in between makes it all a bit trickier in a way.
Yeah, it was definitely less than ideal, and I think that's it wasn't a project that was set up for mental health, and that actually ended up being its main bit of clinical work. But yeah, it definitely wasn't adapted, that setup.
Okay, and we have a question in the chat. I'm just going to read that one out. How long would such a project plan to last, and is there a plan long term to hand over the current side project? I think that's what they're saying. So I guess, how long does it last? Is there a plan to hand it over? I guess you already touched on that in terms of potentially handing it over to the NHS.
Yeah, so the current plan is to run for 3 years, and during that 3 years to be building the evidence base, to be doing the proof of concept of the type of intervention, showing how that works on the barriers to access for this population, and then discussing ways of making that sustainable, because as this little presentation has just shown, MSF is not particularly stable in the way that it runs its interventions. And so long term, it's gonna need a partner who's able to take that over and do it in a more durable way.
I have a question, if that's okay. When you say you're going to be delivering the 16 to 20-week trauma therapy as well, what happens to the patients, the refugees that kind of relocate because of the refugee issues, or they are just based in one place? I mean, is it lost to follow?
It shouldn't be lost to follow up. So if someone is still in the asylum system, if that person is engaging with specialist treatment, then the Home Office are not supposed to move them. So if while the person is in step 3 treatment and they get a notice to be moved, we will make representations to the Home Office saying that this person is in specialist treatment and should be kept in the same location in order to continue that specialist treatment. If for whatever reason that person does end up being moved, because as we know the system is quite dysfunctional, then we will have in place a capacity of some sort to follow up remotely. However, often this quite deep trauma focused therapy for PTSD is quite difficult to do remotely because it's not safe because of the risk of dissociation. And if you're not physically present, it can then be hard to bring that person back. So that will need to be carefully navigated, and I don't think we'll have all of the answers for that until we've actually started doing that step 3 work. But yeah, the idea will be to do that step 3 work, probably with the cohort of people who are less likely to be moved, just like that, because we'll also be open to people who have their status.
Okay. Any more questions? I might have one more question, if that's okay. Um, as a doctor working in the NHS, as a healthcare provider in NHS, I'm sure most of my colleagues will also have the same question. We see a lot of patients who don't really engage in the NHS care as well because they kind of have expected that they won't be receiving as much, and we might not understand. What feedback may you have received, or what is it that we can do to kind of make our services better and make them feel included as well?
I think it's just quite a complex system to navigate, even for someone that's lived here all their life. And I think that it has to be in a certain sense inflexible, because you can't run the entire NHS with a very flexible DNA policy. However, for this particular client group, they need a lot more help to kind of get in through the door, and then once they're through the door, to stay engaged with the service. There is actually a brilliant service in Bristol called the Hope Service, which is an NHS service which is doing quite a similar thing to the thing that we would like to do. And they're really great, and they've done a lot of this work about how to engage NHS patients. And being an NHS service themselves, they've shown that it is possible for the NHS to engage with this client group. So if you are in Bristol, I would very much encourage you to check them out.
All right. Thank you so much, Jacob. That was very helpful. Charlene, handing over to you.
Yeah, thank you so much, Jacob. Right, well then welcome our second speaker, who is Chipo Takawira, who is a passionate advocate in the health field, bringing valuable expertise in partner coordination, public health, and humanitarian assistance in challenging environments. During her professional journey, she has gained extensive experience in complex emergencies through her work with MSF and also the WHO in various countries like Zimbabwe, South Africa, the Democratic Republic of the Congo, Mozambique, South Sudan, and now Kenya. Her title of her presentation is Health Challenges Facing Refugees and Migrant Populations in Kenya. So the floor is yours, Chipo.
Thank you very much for that intro, and thank you for having me. I did prepare a little presentation, so I hope not to kill and bore everybody with the presentation. I'll try to share it from my side. I hope you can see my screen.
Yeah, I can see the screen. Yeah, that looks good.
You can see the presentation, yeah?
Yeah, that looks great, yes.
Okay, perfect. So I am currently working in Kenya. I moved here at towards end of February. My previous mission was with WHO, working in Palestine, helping respond to the current ongoing conflict in Gaza. So it's quite a big change to the Kenya context, where it's much more stable. It's not a conflict setting. However, Kenya does host quite a significant number of refugees and migrant populations in the region. As many of you, the Kenya borders Somalia, as well as also South Sudan and Ethiopia, where quite a number of the refugees and migrants come from. So in terms of the general context, when it relates to refugees, they are, I'll try and remove this, yeah. There are two main, locations where the refugees are located. So we have refugee camps in Turkana, which is the one in pink on your screen, which is the top left corner of Kenya, and in Dadaab, which is bordering Somalia. The refugees in Kakuma and Kalobey, they are mainly from South Sudan, that area. And then we have some refugees that are located in urban locations such as Nairobi and other cities. These are much more spread out. So, but the majority of refugee of the 854,000 plus refugees that are in Kenya are mainly located in Dadaab camp. We have Dadaab and Kakuma as old traditional style kind of refugee camps, where you have a camp really set up where you just have all of the refugees living separately from the host community. However, in recent years, there was a setup and an endeavor by the government of Kenya, as well as UNHCR and other stakeholders working with refugees, to establish an integrated settlement known as Kalobeye, where we have the refugees integrated together, living together with the host communities in a much more out of a mix of a refugee camp kind of town setup. This was a partnership between UNHCR, World Bank, UN Habitat, as well as the government of Kenya. The aim was to remove the refugees from a camp setup where there are limitations in terms of what they are able to do to be able to look after themselves. So within the non-traditional integrated settlement, they're able to start small businesses, do some farming, as well as also engage in the local markets. there are quite a number of livelihoods programs that they are able to access much more compared to when they are in a traditional refugee setup. When it comes to migrants, according to IOM, there are an estimated over 1 million international migrants residing in Kenya. This does not include the refugees and asylum seekers that we mentioned previously, because these are counted separately. Many of the migrants are irregular and have no documentation to support their stay in Kenya. Which of course affects their ability to be able to access some services, and they also live in fear of being accepted within the community, and also of potential discrimination. Many of the migrants are from Somalia, that's the biggest chunk of migrants, followed by Uganda, South Sudan, DRC, Tanzania, Ethiopia, Burundi, and other countries within the region. As well, for the migrants, majority of them are settled in urban areas such as Nairobi, Mombasa, Kisumu, Eldoret, and Nakuru. And they face similar, challenges that come with being in an urban setup when you do not have all the resources that you need to be able to make a living there. So I try to summarize some of the challenges that are encountered by both refugees and migrant populations. So for many of them, they live in overcrowded, poor living conditions, which increase their risk of getting infectious diseases. You are also looking at living arrangements in which they have limited access to basic amenities such as healthcare, water, sanitation, and hygiene facilities, education. And also, if you look at the map that I previously shared, majority the camps in Kakuma and Kalobe and Dadaab, they are in what are considered arid regions of Kenya, which are also suffering from the effects of climate change. So they're much more dry, and they experience much more incidences of drought. And with the climate change, there's much more deforestation and desertification happening in those areas, which increases which makes the living conditions there much harder. As Jacob mentioned, many of the people that are asylum seekers or refugees or migrants, they suffer quite a lot of mental distress, either from their journey or living conditions, or exposure to more violence than other people in any particular context. I already mentioned the challenges related to environmental climate change related hazards, security and legal status, especially for migrants who usually are undocumented. It's much more challenging for them to be able to access any services. Economic hardships, there are less opportunities for refugees and migrants for them to be formally employed and to have much more regular type of employment, or to be able to get out of, to be much more financially independent. And in the last year, we have, not only in the last year, over the last few decades, we have seen a decline in the international aid, which has been exacerbated over the last few months, where we have seen massive decline in international aid, as many of the traditional donors are reprioritizing their focus from humanitarian aid to security and other areas that they have decided to focus on. Here, in terms of health challenges specifically, refugees and migrants, they're more at greater risk of communicable diseases. As I previously mentioned, that because of the difficult living condition, the poor living conditions that they have, and poor access to basic amenities, they're at greater risk of outbreak-prone diseases such as cholera, measles, respiratory infections, malaria, as recently we are already we are responding to a cholera outbreak in one of the camp in Turkana County, where we have seen quite a number of cholera cases. There are also at higher risk of infection, diseases such as TB and HIV infection. Cross-border movement, the refugee camps, as well as also migrants in urban areas, they are all having to cross borders. And this also, the conditions in which they are able to travel, it makes it easier for them to be able to, for diseases to cross between countries. Sometimes, many of the times they are not using formal border crossings for there to be any kind of health checks. Refugees and migrants are also experience malnutrition, greater risk of malnutrition, especially for children under 5, pregnant and lactating women, the elderly, people with disabilities. They are much more vulnerable to malnutrition as a result of limited access to food. Which is not only a result in lack of access to agriculture, but also lack of access to employment opportunities and the funding cuts that I mentioned before. Access to healthcare services is also quite difficult with there being scarcity in terms of number of health facilities available to them, underfunding of some of the services, understaffing, as well as also limited access to specialized services. So in some camps, as much as you have access to primary health care, if somebody needs specialized care, it's much more difficult for them to access those particular services. Other barriers include poverty. In Kenya, so majority of the health services are provided by the government, followed by, I would say about 60% of services are provided, of healthcare facilities are run by the government. And then you have the private sector, making about 30%, and then the non-profit, so NGOs, faith-based organizations, they make up only about 10% of service providers. So for people, especially in the urban settings, you will likely have to do out-of-pocket payment for you to be able to access health services. There are also challenges in terms of language differences that may make it difficult for people to be able to seek healthcare services. I previously mentioned that many of the people are not documented, and this lack of legal documentation also makes it very difficult for them to be forthcoming when it comes to seeking healthcare services, also for fear of being discriminated at the health facilities. There's also increased risk of gender-based violence. We mentioned that many of the refugees and migrants, the risk of experiencing mental health distress is related to gender-based violence or other traumatic events, as well as also because of the quality of life, the risk of teenage pregnancies, unsafe abortions, transactional sex are also higher amongst refugee, migrant women and girls. Access to maternal health emergencies is also quite limited, and this is complicated in many situations with blood shortages or because of logistic issues or limited donation within the population. Missing routine immunizations is also a major health challenge that may be experienced, especially for undocumented migrants who are not in a camp setup. So for many of the refugees that are in camp setups, they may be able to access primary healthcare services through the services that are provided by partners who work in those locations. But for those that are out of the camps, it's much harder. And also for some of the refugees, they move between the refugee camp and other locations outside the camp. which may cause some disruption in terms of adherence to meeting appointments and so on. When it comes to mental health issues, we talked about the trauma of the migration journeys, separation of families, unaccompanied minors. Also, sometimes there is exploitation in the movement, abuse of people, and just the trauma of being separated from a familiar environment and moving to a place that you don't know what to expect, or to be isolated in a camp or other locations that are unfamiliar, away from people and culture that you are used to. The chronic exposure to trauma can lead to intergenerational traumatic experience, and this can be felt throughout a community, particularly. I mean, we already mentioned the issue related to increased risk of GBV, sexual exploitation, trafficking. Can you hear me?
Yeah, we can hear you. Yeah.
Yes.
Okay. Thank you. So also the issue related to some of the traumatic experiences that might require some legal assistance, there is limited access to those particular kind of services related to GBV care, legal aid, psychosocial support. Lastly, challenge related to inadequate health data and inclusion in policies. So many of the migrants, refugees are underrepresented in national health data, which hinders us being able to make evidence-based planning, decision-making, or resource allocation, especially for those that are undocumented, because they try to stay under the radar for fear of being detected and being arrested. Which, of course, for those particular groups of people, make it difficult for us to be able to have a good overview of their health status. So what are partners doing to try and support refugees and migrants? So the main stakeholders when it comes to support to refugees and migrants, for refugees is mainly UNHCR, and then for migrant population we have IOM also mainly providing services to those to that population, with support from various NGOs, both international, national, and also the government of Kenya. As I mentioned, that they run quite a number of health facilities that provide services to the population. So the 5 key areas that our partners are supporting are related to service provision. So providing basic healthcare, WASH facilities, food assistance, shelter, then specialized care for those that are in need. There's also livelihoods and economic inclusion programs, which help to give financial freedom to refugees and migrants, as well as also ensure that they are able to be self-reliant and not wholly dependent on aid. And then protection and legal aid. Partners are collaborating with the government to support with registration, determining refugee status, reunifying separated families, or managing support for unaccompanied minors, as well as also advocating for policy changes to ensure that the needs of refugees and migrants are integrated into the country's policies, that they are not left behind. An example is with the rollout of the health insurance that has been rolled out in Kenya. There have been engagements with UNHCR as to see how best that population can be supported to ensure that they're able to still also access healthcare services. There's also partners that are supporting with climate adaptation, who are monitoring the changes in various locations in the ASALs. So these are the arid and semi-arid regions where we have the camps. To see how best they can support the populations in those locations to adjust to the changes in the environment. Also, this includes having some diseases that were previously not in particular locations, spreading to those locations because of the changes in temperatures and changes in the general environment, which make it much more conducive for those diseases to thrive in those locations. And lastly, we have communication and digital connectivity. So this is to support community health awareness, spreading information related to protection, education, supporting family reunion, and reducing isolation for the refugees and migrants. That was my last slide. Back to you if there are any questions or comments.
Thank you so much, Chipo. That was very interesting. Yes, so if anyone has any questions, feel free to unmute or write them in the chat, and we can read them out. So there's already a first one that I'm gonna just read out now. How much exchange of ideas and lessons learned are there between such different contexts, UK cities and rural Kenya, providing care for populations with similar backgrounds and needs? What can each learn from projects in the other? What can each learn from projects in the other?
Yeah, that's a tough one because they're very, I mean, for I would see some similarities when we are looking at the urban context where we have some of the refugees and migrants integrated into, we have moved into the cities to try and see how we can some of the services that that the two locations could learn from are related to issues related to protection, provision of legal aid to the refugees or migrants, and how best they can. I think what I've observed in a lot of European cities is that there's a lot of tensions between refugees, asylum seekers, economic migrants, whatever you want to call them, and the host populations, because there's a feeling that they are coming to take away quite a lot of resources from the population within those cities, especially considering that I think because of the deteriorating living standards. So quite a lot, I think there's a huge welfare community that feels that they are being deprived of some of the things that are going to refugees and asylum seekers and so on. So I think there is need for us to find a balance as to how we can be able to support both populations to ensure that we reduce the tension between the host community and the refugees, migrants. So this is, I think, something that maybe a context such as UK could learn from a place such as Kenya, which has been hosting refugees and migrants for much longer than the UK setup, I would say, or that have been maybe because the situation has changed in the years, because I'm sure there have been refugees and migrants in the UK for generations, but it just seems that now there's much more tension compared to previous periods of times when it comes to refugees and migrants. So for me, that's something that could be learned, that there could be some information exchange when it comes to that, as to how do you manage the tensions between the host community and the refugees, migrants, to ensure that there's nobody who feels. So for example, when we do interventions for refugees, in many of the areas, we try to see how we can also provide support to the host community so that they don't feel left out. And that really helps to reduce the tension between the host and the refugee population. And when it comes to accessing health services, for sure, there could be some learnings there when it comes to health service provision, as well as also mental health support. I don't know if Jacob wants to come in as well to provide some input on this. Thanks.
Yeah, I mean, so I've not worked in Kenya. I suppose I'm thinking about MSF's work in similar contexts, and I suppose what we take from, or what I take to learn as lessons from working in similar contexts and similar interventions to the ones you've been describing, Chipo, are some of the work that I think MSF and other organizations are very good at doing in those contexts, about thinking about the barriers to access to services for quite marginalized communities, and all of the work that I think we're good at doing in terms of going out and getting people into to access care, sort of people who we call hard to reach. And then I suppose what I think about what I might take back to a similar context again is probably, I talked about the legislation and the regulation in the UK, particularly around safeguarding. So thinking about the risks to patients that exist and what we need to do, the kind of risks to patients in terms of their protection. And where I think that we as MSF could probably be a lot better about thinking about that in a similarly detailed way in other contexts, where we might not have the legal obligation to do all of the things that we have in the UK, but actually best practice would probably demand that we're a lot more sensitive to those risks and a lot more developed in our response to those risks. So that's kind of two areas where I can see an exchange between those types of contexts.
Yeah, thank you both. Very good answer. Did you want to add to that?
No, I was just seeing a question in the chat, which was asking about sustainability plans in place since there are plans to integrate refugee and host community. So some of the work has been surrounding in creating livelihoods opportunities for the people. So both host and the refugees, they are all treated the same, so that there's no, as they will be living together in the same community. So the livelihoods programs, these include startups for things to do with hands, like people building things, or running little farm gardens that people can utilize, and then whatever they produce, they're able to sell back within their community or to other communities. Other integration related to urbanizing some of these communities, so bringing in much more urban kind of facilities in these locations, so that they become much more urban centers that people have access to more services, and also attracting other service providers that would be found in any kind of urban setting, which would give much more opportunities to the population for them to be able to be much more independent and less reliant on humanitarian aid, as they would have much more livelihoods programs that they'll be having at hand. Over.
Right, we have a further question. So, considering there are migrants from various countries in Kenya, do you notice violence or discrimination within the camps? Are there any measures to prevent, if so?
Well, the major worries are related to, for example, we did see some protests and demonstrations when some of the services were cut out. So because of the financial, the humanitarian aid cuts, we have seen decline in terms of food rations, and also some services have been affected. And that has been the main cause, for example, for some kind of violence in some of the camps. Some of the camps, for example, in Dadaab, it's a high security location. So there's quite a significant movement of people between Somalia and Dadaab. So incidents of violence could be there, but that's not really linked to people being from different countries, like not let's say Somalis fighting people from Congo or anything like that. It's much more clans-like because of other tensions that are related to where they are coming from. But in terms of conflict between citizens from different countries, we have not really seen that. The major triggers seem to be limited access to resources when there's a sense that rations have been cut or access to some services have been cut. That has been the major causes of conflict. Then I see there's another question. But I also saw there's somebody from IOM. I'm not sure if Gikandi might want to feel free to come and add in any information that I may have left out, or just to provide insight into IOM work. There's another question, I think.
Yeah, I'll just read it out quickly. So the next question is, with the recent global health funding cuts, how has service delivery to vulnerable populations been affected? And what short and medium-term strategies are being considered to sustain essential health and humanitarian services?
Yeah, this is still, I don't have an answer for this because it's still a major challenge. As you know, everything has really happened abruptly. So and it's not just the US that has cut, even they made the first step, but other countries have followed suit, maybe not at the same scale. It's almost like everyone was waiting for one country to make that step, and then everybody else like kind of followed suit. So it's still quite difficult to really find what we are doing is to try and prioritize on the really basic services to ensure that we're able to provide those really basic services and stretch whatever resources as much as we can, whilst at the same time also trying to see if we can pursue other non-traditional donors who might be able to provide support, and also some organizations that have not been affected as much as quite a lot of those that were very US dependent organizations have been stepping in to try and cover some of the gaps in the short term. But in the long run, really, it still remains quite tricky as to how things are going to move forward, because just because the funding has stopped today doesn't mean that all the problems have gone away. The problems are still there. It's just that what we are able to do is we are much more limited in how we are able to respond to those needs. And when you look at the world, the number of crises continues to grow, but the resources continue to shrink. So yeah, it's a huge dilemma that unfortunately I don't have an answer right now as to how best that can be managed in the medium term. But some governments have been, as I mentioned, that they're trying to see how they can integrate some of those needs within the public health services. But if this is not handled properly, then we will end up having that creation of tensions between host populations and the refugees and migrants, because if the government is not able to provide services to their population, it translates to that they will also struggle to include that caseload on what they already are struggling with. Over.
Okay, I guess one more question from me. Just thinking about the map that you showed in the beginning. So are there then several different centers? I picture by the border, it's probably quite remote. Do you then kind of also offer some transport to more urban locations, or how is that handled?
So the camps are quite close to the border, but these urban centers, quite a number of them are quite away from the camps. So we don't necessarily provide transport. Organizations don't necessarily provide transport. So people normally find their way, if they want to leave the camp to go to the city, they do find their own way to go there.
Thank you. Right. Do we have any other questions from the floor? give it a couple more seconds.
There's
Gandhi
a
has
hand.
something to say.
There's a hand.
Yeah?
Yeah, he can do. Yeah.
Hi,
Go ahead, Gandhi.
hi, Chipo. Can you hear me?
Yes, we can hear you.
Thanks for the excellent presentation and also to the previous speaker. And when the question was asked about what kind of knowledge sharing can happen, I think what came to mind is so I work at a bridge between refugees that are staying, for example, in the camps, and the few, like 2% of whom get lucky enough to be resettled into a third country after years of living in the camps. And when this question was asked, I thought of an exchange that happened. Traditionally that the US is used to be a big resettlement partner. And what happened is that CDC and that's USCDC and IOM and the University of Minnesota created this kind of fora where uh, people working on this side, for example, the doctor that's doing pre-migration health screening for refugees in Kakuma would meet the primary health care, the family physicians that work in refugee clinics in, let's say, Minnesota. And during these exchanges, there's a lot of information sharing and this links, the whether formal or informal, the kind of contact that remains for many years and sort of relationships that are created out of this result in, a better understanding of what I would need to do in Kenya for this refugee that needs has some health needs in terms of the documentation, gathering all the information I can on this side on their conditions, and because I have probably the interpretation services that the same doctor would not have on the other side, then uh, trying to put that in a way that the doctor on the other side finds it easier to interact with this, and also highlighting nuanced, for example, things that the refugee on this side might find it easier to express, knowing very well that sometimes refugees before resettlement see anyone that they interact with as like bureaucracy that has to be jumped over, for because they really want to go and might not reveal some of their medical conditions. Well, we have to learn to get their trust so that we can then communicate this to the doctors that see them on the other side. So this kind of exchange helps a lot to see what can be done better on this side, and also for them to reflect on what they can do better on that side, to so whatever they're trying to achieve can be achieved in terms of communication, and especially communication because it's totally different world on that side. And also we try and for example uh, translate or have medical documents in a language that is understandable or forms that are understandable to the doctors on the other side. Unfortunately, you know what has happened, and all that work may not, continue. But of course, for the countries that continue to resettle from these camps and through IOM, that knowledge is applied, and it's the hope of everyone that it's more people are more aggressive in I what do I say, advocating for such smaller things that people may not think about in these times of great change. So thank you all, and that's all from me.
Thank you so much, Gandhi. Um, all right, so that's a wrap up. We've had two very amazing sessions, very amazing speakers. Thank you so much for your time and for all these efforts that you do with your work. Um, Perfect. We'll wrap this up now. We have posted the link to the feedback for our speakers in the chat, and if you'd like a certificate, you just need to fill the feedback, put your email address, and you'll be sent the certificate. We have also shared the link to our WhatsApp group to stay updated about the future talks. We usually have our talks on the second Wednesday of every month. We're quite regular, so hopefully the next talk will be in August, the second Wednesday of August. Thank you so much, everyone, for tuning in. Thank you, Chipo and Jake, for your time. All right.
Thanks so much. Bye-bye.
Thank you. Bye-bye.
Thank you all. Bye.
Right, I'll keep the session open for a couple more seconds so people have time to fill out the feedback form. And then we'll send you a certificate of presentation as well, Chipo.